This chart tracks plasma concentration over time. For standard medications, the green therapeutic window is wide enough to accommodate slight variances. But for high-alert medications, that window is razor-thin. A minor fluctuation in dose pushes the drug concentration straight out of the safe zone. When we talk about medication errors with these drugs, we aren't just discussing minor side effects. We are looking at the adverse response zone, where a single mistake leads to catastrophic patient outcomes. Because the risk is so high, clinical practice relies on the Institute for Safe Medication Practices, or ISIMP. Their list defines the drugs where the margin for error is effectively zero. Among these categories, 3 classes demand immediate recognition: anesthetics, hypoglycemics, and neuromuscular blocking agents, or NMBAs. Consider a stat order for ketamine, insulin, and atracarium. You are simultaneously managing a potent anesthetic, a drug that can plummet blood sugar, and a secondary agent that stops the patient's ability to breathe. This specific combination illustrates the high-stakes environment of high-alert dispensing. It is a workflow where standard pharmacy routines must be replaced by rigorous, systemic layers of protection. The first protection is verifying the administration route. Vincristine, a common chemotherapy agent, is strictly for intravenous use. If this vial is mistakenly connected to a spinal line rather than a vein, the result is fatal ascending paralysis. The warning label is literal. Concentration errors present a different threat. These 2 bottles of oral morphine solution look nearly identical, but one is 10 times more concentrated. Without an active check for that 20 milligrams label, a patient receives 10 times the intended dose. To prevent these calculation disasters, handwritten abbreviations are strictly banned. A letter U for units can easily be misread as a 0, turning a 5,000-unit dose of heparin into a 50,000-unit overdose. Chemical symbols carry the same risk. Here, the prescriber had to correct MSO4 to MgSO4 to ensure the patient received magnesium, not morphine. Mixing these up means intending to provide an electrolyte, but accidentally inducing massive respiratory depression. Accuracy requires constant verification. For a 56-kilogram patient ordered at 80 units per kilogram of heparin, the dose must be calculated at exactly 4,480 units, well within the 10,000-unit safety cap. Writing out full words and verifying every decimal point creates a physical barrier between the medication and a lethal mistake. Errors often stem from drugs that look or sound alike, known as LASA medications. These mix-ups can happen visually on a shelf or verbally during a high-pressure phone order. For example, the drug Angiced, used for angina, sounds almost identical to the NSAID, ANSAID. To catch these verbal errors, the dispenser must verify the patient's diagnosis before any medication leaves the pharmacy. Visual confusion is just as common. These vials of morphine and hydromorphone share similar packaging, yet hydromorphone is 5 times more potent. We solve this using tall man lettering. Capitalizing specific sections of the name, like the OXY in hydroxyzine, forces the brain to distinguish it from hydromorphone. High-risk treatments, like pediatric chemotherapy, require independent double checks. 2 clinicians must separately calculate the dose based on the patient's body surface area and renal function to ensure the numbers align. For the most dangerous agents, like NMBAs, the drugs are sequestered. They are stored in separate, locked cabinets to prevent an accidental selection during a crisis. We also employ forcing functions, engineering controls that make an error physically impossible. For example, an oral syringe designed so it cannot physically connect to an intravenous line. Because human vigilance is limited by fatigue and stress, these safety measures must be hardwired into the physical environment. Even at the final stages of a prescription, notation matters. A trailing 0, writing 5.0 instead of 5, is often misread as 50. In high-alert medicine, that decimal point is the difference between a therapeutic dose and a fatality. Every high-alert medication must be flagged at the dispensing counter. Applying a bright red auxiliary label ensures the next person in the chain of care is immediately aware of the risk. The patient is the final line of defense. Effective counseling must focus on the specific risks associated with their therapy. Patients on warfarin must understand INR monitoring. Those on opioids need naloxone access. And patients receiving heparin must be screened for thrombocytopenia. This systematic approach, combining tall man lettering, independent checks, physical sequestration, forcing functions, and strict abbreviation bans, is what makes safe practice possible. These protocols move healthcare beyond simple order filling. They establish the clinician as the final necessary check against catastrophic patient harm.